Let's jump into a deep dive. Today, we're tackling something really common and often quite challenging for families and clinicians alike in pediatrics. Cow's milk protein allergy or intolerance in young children.
Yeah, absolutely. And our sort of guide for this is a really useful set of pediatric revision notes focused specifically on this condition.
Right.
Think of them as, the core stuff you really need to know.
Exactly. So our mission today is basically to crack open these notes, pull out those absolute must-know facts and insights, and help make them stick.
Yeah, make it high yield.
Definitely high yield. Whether you're maybe prepping for an exam like the MSRA perhaps, or seeing this in your practice, or just trying to figure out why a little one might be struggling, we're aiming to give you that solid understanding of, without getting totally lost. Let's try and make this clear.
Let's do it.
So right off the bat, what exactly is cow's milk protein intolerance or allergy? Like fundamentally what's going on?
Okay, so essentially it's a bit of a mix-up by the immune system.
A mix-up?
Yeah, for reasons we can get into, the body mistakenly sees the proteins in cow's milk, things like casein and whey as harmful, as a threat.
Oh, okay.
And that triggers an adverse reaction.
Okay, so the immune system gets its wires crossed. And this isn't rare, is it? What do the notes say about how common it is?
No, it's actually pretty common. They suggest it affects about 3 to 6% of children.
Wow.
And you typically see it cropping up early, often within the first 3 months of life.
Right.
And it's particularly noticeable in infants who are formula fed.
That's a fair few babies then. And the notes, they mention different ways the immune system can react, leading to different types.
Yeah, exactly. There are sort of two main pathways this reaction can take.
Okay.
One is the immediate type, that's IgE-mediated. Think classic allergy symptoms happen fast.
Right, the quick one.
The quick one. Then there's the delayed type, which is non-IgE-mediated. This is often what people mean by intolerance. The reactions are slower, often generally less severe. The notes tend to use CMPA, the allergy term, more for those immediate IgE reactions, and CMPI, intolerance, for the milder, delayed, non-IgE ones. It's useful terminology.
So common, starts early, in two different ways the immune system can kind of mess up. This immune system error. What actually causes that? Why does it make that mistake?
Well, the core issue, like we said, is the immune system just misinterpreting those cow's milk proteins, seeing them as dangerous when they aren't.
And that misinterpretation kicks things off.
Yeah, it triggers an immune response cascade. And depending on which arm of the immune system gets activated, you either go down that immediate IgE path or the delayed non-IgE path.
Right. Okay, so are some babies just more likely to have this happen? What are the risk factors the notes highlight? Who should we be thinking about?
Yeah, there are definitely risk factors. A big one is genetics. So if there's a family history of allergies or things like atopic dermatitis, eczema.
Okay, family history. That makes sense. What else?
Introducing cow's milk very early seems to be a factor. And also, formula feeding seems associated with higher rates compared to exclusive breastfeeding.
Huh. Interesting. So how the baby's fed early on plays a role.
It seems to, yeah. And lastly, if a child already has other allergic conditions, maybe asthma or allergic rhinitis like hay fever, they're also more likely to develop CMPA.
Okay, let's dig a bit deeper into how that reaction unfolds, especially the immediate IgE one. The notes detail the mechanism, right? Can you walk us through that pathophysiology?
Sure. So think of the immune system producing specific antibodies, these IgE antibodies, against the cow's milk proteins when it first encounters them. It gets sensitized.
Okay, like it learns to recognize the enemy.
Pretty much, yeah. It's primed. So the next time the child has cow's milk, these IgE antibodies quickly grab onto the milk proteins.
Right.
And that binding action triggers other immune cells, like mast cells, to release a flood of chemicals. Histamine is the famous one.
Ah, histamine. And that's what causes the symptoms we see so quickly.
Exactly. That rapid release of histamine and other inflammatory mediators is the body's, overreaction. And it directly causes those fast onset allergic symptoms, the rash, the vomiting, the wheeze.
Now, those symptoms you mentioned, colic, vomiting, rash, wheezing, gosh, they sound like they could be so many other things in babies. This must make diagnosis tricky.
Oh, definitely.
What else absolutely has to be on the radar when these signs appear? What are the key differentials according to these notes?
This is super important, and the notes really emphasize being thorough here. CMPA symptoms are great mimics.
Right.
They can look just like symptoms from a whole bunch of other conditions, so ruling those out is crucial.
Okay, so what are the big ones, the top mimics?
Well, lactose intolerance often comes up, but remember, that's about digesting the sugar, the lactose. It's not an immune thing reacting to the protein.
Right. Different mechanism entirely. Good point.
Exactly. Then you've got other food allergies or intolerances generally. Also things affecting the gut itself, like gastroesophageal reflux disease, GERD, significant reflux.
Okay. And there was another gut one mentioned?
Eosinophilic esophagitis. That's an inflammatory condition of the esophagus, the food pipe.
Mm.
And it's not just gut stuff. You could have non-food allergies causing similar skin or breathing symptoms, pollen, pet dander, that sort of thing.
So skin, gut, breathing covers a lot. What about other underlying sort of medical issues?
Yes, the notes mention considering other general gastrointestinal disorders. And importantly, conditions that affect digestion more broadly, like pancreatic insufficiency.
Okay.
They give cystic fibrosis as a specific example where you might see that.
Wow. Okay. That's a serious one to consider. Even infections can look like this.
They can, yeah. Even something like a urinary tract infection, a UTI, is mentioned. Because in babies, systemic illness can present with really vague, non-specific symptoms that might overlap, like irritability or poor feeding.
Right. So the absolute key takeaway here, maybe especially for revision, is don't jump to conclusions. These symptoms overlap massively. Keep a broad differential diagnosis in mind because the treatment for each is totally different.
Absolutely. Getting that diagnosis right is step one, and it's a big step.
Okay, let's zoom back out to the numbers again. How common is this expert mimic, really? And does it hit certain groups harder? What's the epidemiology picture?
Right. So looking at the UK data specifically mentioned in the notes, it's around 2 to 3% of infants and young children overall.
Okay.
But that difference between formula and breastfeeding is quite striking, isn't it?
Yeah, you mentioned that earlier. What were the figures again?
It's around 7% in formula-fed babies versus only about 0.5%, 0.5% in exclusively breastfed babies.
Huge difference.
Massive. And reactions in breastfed babies, if they occur via the mother's diet, tend to be milder too. The notes even suggest exclusive breastfeeding might actually offer some protection against developing CMPA later on after weaning.
Fascinating. And we talked about family history and other allergies being risk factors. How strong is that link?
It's a really significant link. CMPA is much more common in kids who already have other atopic conditions, asthma, eczema, hay fever.
Yeah.
The notes specifically call out early and severe atopic eczema as a strong predictor for increased risk of food allergy in general, CMPA included.
And if a child is already allergic to other foods, does that affect the CMPA outlook?
Yes, if they have other food allergies, it makes it more likely that the CMPA will persist longer, maybe into later childhood, rather than resolving in the first few years.
Okay, that gives a really clear picture of who's most affected. Now, let's get practical. What do these babies actually look like symptom-wise? And how do we actually figure out if it is CMPA versus one of those many mimics? What are the clinical signs and the diagnostic approaches?
Okay, so the signs tend to show up in a few main systems. We've touched on them. Gut issues like colic, being really unsettled, vomiting or spitting up a lot, maybe changes in poo like diarrhea or even constipation sometimes. Then skin symptoms, rashes, hives, or eczema getting worse, and sometimes respiratory signs like wheezing, a cough that won't go away.
Okay.
And thankfully, rarely, but importantly, anaphylaxis is mentioned as a possibility in severe immediate reactions.
Right, the most severe end. So symptoms across different parts of the body. And the notes break down the diagnosis based on whether you suspect that fast IgE reaction or the slower non-IgE one.
Exactly. That distinction is key for diagnosis. If you're suspecting an IgE-mediated reaction, the symptoms usually hit fast within 2 hours of having the cow's milk.
Okay.
They typically involve the skin, like hives or swelling, the gut, vomiting, tummy pain, or respiratory system. And this is the type where anaphylaxis, though rare, is a risk.
And how do you test for that type?
For this immediate type, you can use specific allergy tests to help confirm things. Skin prick tests or blood tests looking for those specific IgE antibodies to milk protein.
Got it. Fast onset specific tests available. What about the delayed non-IgE type then?
Okay, so for these, the symptoms take much longer to show up. It could be hours or even up to a couple of days, maybe 72 hours later.
Wow, that's a long delay.
It can be. And the symptoms are often more focused on the gut. Think persistent colic, reflux, diarrhea, maybe blood in the stool. But you can also see skin issues like eczema worsening or sometimes lower respiratory symptoms.
And for this type, there isn't a simple blood test or skin test, is there? So how do you nail down the diagnosis?
That's the tricky bit. For non-IgE, there isn't a definitive lab test. The key diagnostic approach, as the notes really highlight, is based on clinical observation and response to elimination.
Ah,
So,
well,
you confirm the diagnosis primarily by seeing a clear improvement in symptoms, usually within about 2 weeks, once you completely remove cow's milk protein from the baby's diet, or the mother's diet if breastfeeding.
so taking it out and seeing what happens is the main tool there. Let's talk more about those investigations then. What's the formal process for confirming CMPA?
It always starts with a really thorough history. That's absolutely fundamental. You need the details, what symptoms, when they started, how severe, timing in relation to feeds, feeding history, family history, all of it.
All right, build the whole picture first, and then you move to that elimination step you mentioned.
Exactly. An elimination diet, removing all cow's milk protein, is the core diagnostic step, especially if you suspect the non-IgE type.
Okay, and if things get better, what next?
If symptoms improve significantly, then the next step, if it's considered appropriate and safe to do so, is a controlled reintroduction of cow's milk protein.
To see if the symptoms come back.
Precisely. If the original symptoms return when milk comes back, that really strengthens the CMPA diagnosis.
And for the IgE type, where do the skin prick and blood tests fit into that process?
Those specific tests, skin prick tests, blood tests for total IgE, and specific IgE to milk, sometimes called RAST, they're used to support the diagnosis of IgE-mediated CMPA.
Support, not prove on their own.
Exactly. They show sensitization that the immune system has produced those IgE antibodies. But you still need the clinical history and often a formal challenge test to confirm it's causing the actual symptoms. The oral food challenge, done under supervision, is kind of the gold standard test if things are unclear.
Okay, so history is king, then elimination, then potentially reintroduction, or specific tests depending on the suspected flavor of CMPA.
That's a good summary. The diagnosis often hinges on seeing that clinical improvement off milk. The tests are helpful aids, especially for the IgE type, but they're part of the bigger picture.
Okay, so let's say the diagnosis is made. What's the game plan? How do we manage cow's milk, protein allergy, or intolerance based on these notes?
Right, so management is all about completely eliminating cow's milk protein,
Right.
while making absolutely sure the child still gets all the nutrition they need to grow and thrive.
Crucial balance.
Very. Now, if a child has severe symptoms, things like really poor weight gain, what we call failure to thrive, they need specialist input. Referral to a pediatrician is essential.
Makes sense. Severe cases need the experts. What about milder, more moderate cases in formula-fed babies? What's the first step?
For formula-fed infants with mild to moderate symptoms, the first-line recommendation is usually to switch to an extensively hydrolyzed formula, often called EHF.
Extensively hydrolyzed. What does that mean?
It means the cow's milk proteins in the formula have been broken down into much smaller pieces, tiny peptides, small enough that the immune system is much less likely to recognize and react to them.
Okay, and what if the symptoms are really severe, or that EHF just doesn't cut it?
Then the next step up is usually an amino acid-based formula, or AAF.
Amino acid.
Yeah, in these formulas, the protein is completely broken down into its individual building blocks, the amino acids themselves. So there's basically nothing left for the immune system to react to. They're considered hypoallergenic.
Got it. And the notes mention soy. What about soy formulas?
Yeah, important point. The notes caution that soy formulas are not usually recommended as a first step. Why? Because about 10%, maybe more, of babies with CMPA will also react to soy protein. There's cross-reactivity.
Okay, good to know. What about if the baby is breastfed? Do you stop breastfeeding?
No, absolutely not. The best approach is for the mother to continue breastfeeding.
Right.
But the mother needs to completely eliminate all cow's milk protein from her own diet.
Okay, so mom goes dairy-free.
Exactly. And very importantly, she needs to take calcium and vitamin D supplements to make sure she doesn't become deficient while avoiding dairy.
Right. Got to look after mom, too. And as kids get older, starting solids, or if it's diagnosed in an older child.
They'll need to follow a strict cow's milk-free diet. And this needs careful planning to ensure they're getting enough calcium, vitamin D, calories, everything.
Sounds like you need help with that.
Definitely. Referral to a pediatric dietitian is highly recommended. They're the experts in managing these restricted diets safely and effectively.
Okay. The notes mention something called a milk ladder. What's that?
The milk ladder. It's basically a structured, step-by-step plan for reintroducing cow's milk protein back into the diet, usually when you think the child might be starting to outgrow the allergy.
How does it work?
It starts with foods containing very well-cooked milk, like in a biscuit or a cake, because the heating changes the proteins and makes them less allergenic. Then you gradually move up through stages with less processed milk, maybe cheese, then yogurt, and eventually fresh milk. It's done very carefully, usually under guidance. And the notes mention that including baked milk products earlier on might actually help encourage tolerance development.
Interesting. What about all those alternative milks you see now? Almond, oat, coconut. Can kids with CMPA just drink those?
You have to be careful. The notes say these plant-based milks, almond, oat, coconut, can potentially be used after the age of 1.
Okay, not before one.
Not before 1. And they need to be fortified with calcium and vitamins and suitable for the child's overall nutritional needs. Rice milk, though, should be avoided for children under 4.5 or 5 years old due to concerns about inorganic arsenic levels.
Right, important safety point on rice milk. What about other animal milks, like goat's milk? Is that okay?
Big no. Absolutely not suitable substitutes. Goat's milk proteins are very similar to cow's milk proteins.
Ah.
So a child allergic to cow's milk is highly likely, almost certainly, going to react to goat's milk and other mammal milks too. Don't swap them.
Okay, crucial point. So management is really about careful elimination, appropriate substitution with specialist formulas or maternal diet changes, and expert guidance, especially from dietitians.
Okay.
Long term, what else do we need to keep in mind?
Long term, the big focus is maintaining that nutritional adequacy, especially calcium and vitamin D. The notes also mention immunotherapy, giving tiny, gradually increasing doses of milk protein under strict medical supervision as something being explored for severe IgE allergies. It shows some promise, but needs more research, not standard practice yet.
Okay.
And always keep that differential in mind. If it's just lactose intolerance, lactose-free dairy products would be okay because the protein's still there. With CMPA, it's the protein itself that's the problem.
It really sounds like getting professional help is non-negotiable here.
It absolutely is. The notes stress that recommendations can vary, local guidelines differ, and tailoring the approach while keeping the child well-nourished requires personalized guidance from healthcare professionals.
Okay, let's shift focus to the future. Do kids tend to grow out of CMPA? Or is this usually a lifelong thing? What's the prognosis look like?
The good news, generally, is that many children do outgrow it.
Oh, that's great to hear.
Yeah, it often resolves by the time they're around 3 to 5 years old.
Okay, and is there a difference between the IgE and non-IgE types in terms of outlook?
Yes, there seems to be. The non-IgE-mediated type, the intolerance, tends to resolve a bit faster. Most kids with that type become tolerant by age 3.
And the IgE type?
For the IgE-mediated allergy, it takes a bit longer, but still around 55%, so more than half, are likely to become tolerant by age 5, according to these notes.
That's still pretty good odds. Now, when they do those reintroduction tests, the challenges, especially for the IgE type, can parents just try that at home?
No, definitely not recommended for IgE. The notes are clear. Formal food challenges, particularly if there's a history of immediate reactions or diagnosed IgE allergy, should be done in a controlled hospital or clinic setting.
Why is that?
Because even though severe reactions like anaphylaxis are rare overall, the potential risk is there during a challenge. You need medical supervision and facilities available just in case. Safety first.
Absolutely. What factors might influence whether a child outgrows it sooner rather than later?
Several things seem to play a role. How severe the initial reaction was, whether it was IgE or non-IgE-mediated, non-IgE often resolves faster, having a strong family history of allergies, and whether the child has other ongoing atopic conditions like severe eczema or asthma.
Okay, that makes sense. Finally, what happens if CMPA isn't managed properly? If it's missed or the diet isn't followed correctly, what are the potential complications listed?
Right, this underscores why getting it right is so important. If CMPA is left unmanaged or poorly managed, there can be some significant problems. A major one is failure to thrive.
Meaning poor growth.
Yeah, poor weight gain, maybe poor linear growth too, which makes sense if the child isn't absorbing nutrients properly due to ongoing gut inflammation, or if their intake is restricted without proper substitution.
Right, they just can't get what they need.
Exactly. This can lead to specific nutritional deficiencies and broader growth issues. Beyond the physical side, the notes also highlight the psychological effects on both the child, dealing with symptoms or restrictions, and very significantly on the caregivers. The stress, the anxiety, the constant vigilance around food, it can take a real toll on families.
I can only imagine. It must be incredibly stressful.
It really can be. So getting that accurate diagnosis and providing proper, well-supported management is crucial not just for the child's physical health, but also to prevent these wider nutritional and psychosocial complications.
So pulling all this together from the notes,
Yeah.
what are the absolute core takeaways for you the listener, trying to really get a grip on cow's milk protein allergy and intolerance for revision or practice.
Okay, I think number one is understanding it's an immune reaction, not just digestion. It hits young infants most. Know the two types: IgE, immediate allergy tests help, and non-IgE, delayed diagnosis via elimination rechallenge. Number two, differentials are huge EE. Colic, reflux, other allergies, even infections can look similar. Don't get tunnel vision.
Right. Keep that broad mind.
Absolutely. Number three, management is total cow's milk protein avoidance. Use the right substitutes: EHF, AAF for formula babies, maternal diet change for breastfed, get a dietitian involved. And number four, prognosis is generally good. Most outgrow it, but reintroduction needs care, especially for IgE. Supervised challenges are key there. Getting this right makes a massive difference to the child and family.
And maybe a quick memory aid for management if you're revising. Think FADs, F for formula, EHF, AAF, E for elimination, maternal child diet, D for dietitian and development nutrition, S for substitutes, and safe reintroduction ladder.
Yeah, something like that could work, whatever helps structure it. And for differentials, just keep asking, what else could this be? Especially with gut symptoms in babies, think allergy, milk, soy, other. Think structure, reflux, EOE. Think infection, UTI. Think digestion, pancreatic issues. Don't stop at milk.
Great tips. So reflecting on all this, what's the bigger picture here? It really raises the question, doesn't it, of how we as a healthcare community can best support these families. They're navigating really complex dietary stuff, trying to keep their kids healthy, while also just living life.
That's a critical point. It's not just about the medical side. It's about practical support, resources, maybe even peer support to manage the day-to-day reality and the stress that comes with it. Ensuring quality of life is just as important as managing the allergy itself.
A really important thought to end on. Well, that was our deep dive into cow's milk protein allergy and intolerance, using those pediatric revision notes as our guide. We really hope unpacking it this way has helped clarify the essential points and given you a solid handle on it.
Yeah, the notes provided a great framework to walk through it step by step. Hopefully it was useful.
And if you are specifically preparing for exams like the MSRA and found this kind of high-yield focused approach helpful, you might want to check out resources like pastmsra.com or freemsra.com.
Yeah, they specialize in that kind of targeted revision material, distilling down the key info, much like we've tried to do here based on the notes provided.
Definitely worth a look if that's your focus.
Yeah.
Thanks for letting us deep dive into this important topic with you today. Until the next time we unpack something complex.